Thank you for joining us for this Care Transitions webinar. This is part of the Care Transitions project as part of the Indiana State Department of Health Small Hospital Improvement Project. We're joined today by Scott Bourne. Scott has a PhD, is also a registered nurse, and has a rich and diverse background in emergency medical services, emergency and critical nursing, and education. His career roles include field paramedic, emergency department and critical care nurse, EMS system coordinator, director of a university EMS degree program, and senior clinical executive for two large health delivery organizations. He's also published over 200 articles, columns, and video learning modules, and has delivered lectures throughout North America. His research, writing, and lecture topics focus on defining, measuring, and improving patient outcomes and experience. So we're really excited to have Dr. Bourne with us today. Just a couple housekeeping items before I turn it over to Dr. Bourne. Please keep your phones on mute. We will open them up at the end for dialogue if we have time, but feel free to use the chat box at any time. And we will be monitoring that throughout this webinar. If you could, as Annette Handy, my colleague, has indicated in the chat box, if you could please type in your name and organization into the chat box, that would be very helpful for us so we know who's joining us today. And again, if you could have your phones on mute, and please not on hold, because we will hear your lovely on-hold music. And also just wanted to thank the Center for Patient Safety. They are a training partner in this project. And so just wanted to say a big thank you to the center for securing Dr. Bourne for this webinar. We're really excited to hear from him and all the great expertise that he has. So this time I'm going to turn it over to you, Dr. Bourne.
Hey, thank you so much, and thanks for that nice introduction. Can you guys hear me okay?
Yep, I think we can hear you just fine.
Great. I figured I'd do that rather than waiting to see 20 chat boxes line up that said they can't hear. So thanks everybody for joining on this frosty day. I'm calling to you from Colorado, where it's a little cold, but I believe it's a lot colder where all of you are. And I really appreciate having the opportunity to talk about respiratory compromise today, and to be the first clinical webinar for what really sounds like a pretty cool program that you guys are doing. A couple of things before we really start. The required faculty disclosure, the ideas that I'm sharing with you are mine, so don't blame the Center for Patient Safety or Medtronic, who's sponsored part of this work. It's all me. And then the other piece is that I promise I won't tell you to do anything that's off-label for devices or for drugs. In fact, we really won't talk about that at all. And that all of my content, again, is my information, but is based on current standards of care and literature, and I won't lead you into temptation doing things that the law or clinical guidelines say we shouldn't. So just a comment as I get ready to go into this definition. My career I've had more great opportunities than anybody should ever have, and one of the things as a clinical practitioner, I spent several years working as a clinical specialist at a place called the National Asthma Center National Jewish Hospital, which is a tertiary and quaternary care facility here in Colorado for patients who have lung disease that nobody else can seem to manage very well. While I was there, I had the privilege of working with some unbelievably fine pulmonary fellows and residents and attendings, and much of what I have used in my career since then comes from the exposure I had then to respiratory disorders and complaints, which are very common in all of our settings, people who have difficulty breathing, shortness of breath, respiratory-related problems, and how to assess those and manage them. And sometimes it can be really kind of intimidating, because some people have diseases that I've never heard of, have presentations that are odd or unusual, and a good part of my career has been spent in emergency response and in the emergency department, and oftentimes we don't have the luxury of getting a real definitive diagnosis. Our job is just to recognize physiological problems and fix them, with the idea that downstream someone else can understand more thoroughly the real nature of their problem. I think that's a really important lesson that I learned, because it is common that I will see patients in my clinical practice who have disease processes, and I'm guessing you may too, that I'm not very familiar with, and I have to, in relatively short order, figure out, are they okay or not, and what do I need to do until I have more understanding of their clinical condition. Respiratory compromise as a kind of a syndrome or a condition fits very nicely into those learnings. So now, a definition, and I don't necessarily love starting talks with definitions, but this is a concept that is old in some ways, but has really become a point of focus for a lot of us as clinicians here recently. So I'm going to use the word respiratory compromise throughout this talk, and I want to be clear what I mean. And what I mean is a deterioration in respiratory function in which there's a high likelihood of decompensation. That's important to me, and we're going to break this down in just a second into respiratory failure or death, but for which timely, specific interventions might prevent or mitigate the decompensation. So what's that really mean? Well, first, we mean that somebody's had a deterioration in how their pulmonary system or their respiratory function is working. Something's wrong. They're complaining of shortness of breath, or they may have inadequate oxygen status, what we call hypoxia, or they may be ventilating inappropriately. So something has happened to the patient, and they now have a complaint to us about respiratory problems. And they have a high likelihood of getting worse. So sort of partway between these two lines of the definition is, right now they look okay, but they have a high likelihood of getting worse. As a clinician, those are the patients I worry about the most. The patient who presents to me, devastatingly sick with low blood pressure, poor ventilation, crappy oxygenation, I don't miss those patients very often. I may have to work hard to resolve their problem, but I know that they're in trouble, and I get very aggressive in my therapies. The ones that I'm most likely to make a clinical mistake with are the patients who have a complaint and they look pretty good now, but then they go downhill. That's what we're talking about here, is patients who have a respiratory problem that looks okay now, but has a high likelihood of decompensation, and if we don't intervene, that decompensation will lead to respiratory failure or even death. There's an analog to this for any of you that are in EMS or work in emergency services. We see that more often, sometimes in postoperative care and ICU, and that's in shock. And in shock, we sometimes talk about compensated and decompensated shock, where I see a patient initially who's maybe a little cool and clammy and pale, but their vital signs are okay. They have had a deterioration in their circulatory function. There's a high likelihood that they're going to decompensate. And if I don't see it and intervene, it could get pretty ugly and they could die. So this is that same sort of a clinical condition with the important point, in fact, the point we're going to spend all the rest of our time today talking about, that if I'm monitoring closely and I intervene, I can stop them from going into respiratory failure or death. So what we're going to talk about for the rest of today, and we're going to use 3 cases to really illustrate it. What we're going to talk about for the rest of today is respiratory compromise. Patients who begin with a respiratory problem have a high likelihood of getting worse, and sometimes really worse, to where they have respiratory failure, need to be put on a ventilator, or can even die. But we as clinicians have an opportunity to watch them closely, look for specific signs and symptoms, and initiate somewhat generic therapy to prevent that deterioration. So that's what we're talking about today. When we look at the literature around respiratory compromise, there are 6 physiologic causes. And we aren't going to spend a lot of time in physiology here, but there are 6 different things that can cause this respiratory compromise, where patients have a respiratory problem, high risk of deterioration. If we don't notice it, they can even die. The first is impaired control of breathing. Remember, your brainstem tells you to breathe, and then your spinal cord and the nerves to your diaphragm and your rib cage actuate that. And so if there's something wrong in my brain, like a drug overdose or a brain tumor or intracranial bleeding, those are the most common things, or a spinal cord injury of some sort where my brain is trying to tell me to breathe, but my musculature can't respond. Neuromuscular disease fits in those categories also, Guillain-Barré, myasthenia gravis, muscular dystrophy, those sorts of things. So patients who have impaired control of breathing, that's one way that you can get respiratory compromise. Another is impaired airway protection, people who can't swallow effectively, who are at risk of aspiration and the pneumonia and airway obstruction that comes from that. That impaired airway protection can come from foreign bodies as well. It can come from patients who have upper airway edema, think croup or epiglottitis, or burns, things like that, that can impair the ability of our natural functions to protect foreign bodies and stuff from going into our lungs. The third is parenchymal lung disease. I'm sure I'm the 9th or 10th person today in your day-to-day conversation that's used the word parenchymal. Probably not. Parenchymal refers to lung disease that's in the tissue of the lungs. It's not in the airways or the alveoli, but it's in the tissue that surrounds them all. And oftentimes it has alveolar implications. So cancers can be parenchymal lung diseases, but there are a number of other things that can cause that as well. We will look at a patient who has a pulmonary infection. Pneumonia would fit in the category of parenchymal lung disease. Some environmental lung disorders like silicosis or asbestosis, those kinds of things. Increased airway resistance, that's asthma and COPD for the most part. People that have bronchospastic disease or narrowed airways. We'll talk in great detail about that, but that's another cause. And then two versions of pulmonary edema and heart failure, where the problems in the heart cause a backup of fluid into the lungs, and that backup of fluid impairs gas exchange and can lead to respiratory compromise as well. So those 6 disorders, here's the great news for you and me. We don't have to tell the difference between them. When I look at a patient who may be in respiratory compromise, I don't have to figure out which of these 6 things it is. But for those of you that like physiology and like to understand what's causing this, these are the 6 causes for respiratory compromise. So with that, let's go straight into a case. All of the cases I'm going to share with you are actual cases of patients that I've been involved in caring for over the years. I'm sharing with you the site or the location where those cases actually occurred. But when we look at each of them, we'll talk through the fact that oftentimes these could have happened in somewhere else. This happens to be an assisted living facility in which the staff kind of goes by and checks on everyone. Every assisted living facility is a little different, but this one doesn't have medical personnel in the facility. But at the same time, they do stop by and check on their residents every day to make sure they're up and about and they feel okay. And so when the staff went by to visit this 60-year-old gentleman, he told them that he'd been feeling under the weather, one of those really technical medical terms, for the last few days. The assisted living staff knew that he had emphysema and had for many, many years, and that he required supplemental oxygen 24/7 in order to maintain adequate oxygenation. The assisted living staff, who see him every day, thought this looked a little different than his usual presentation, and many of you have experience with patients with COPD or emphysema, and oftentimes they're short of breath every day. They look sick every day. And so often the challenge for us is just in recognizing when this is a big deal. This was a non-medical staff member who just said, I don't like the way he looks. This is different than usual. And this assisted living facility was on a campus that had independent living for geriatric patients, assisted living, a skilled nursing facility, and an LTAC, all on this big city block campus. So the staff person had the ability to reach out to somebody from the LTAC and say, would you come down and take a look at this guy? So then the LTAC nurse came down and took a look. Here was what his first assessment was. He noted that the patient was alert and oriented to person, place, time, and event, which is his baseline. So whatever is happening, if anything's happening, it's not affecting his mental faculties, and that's a good thing. He's very diaphoretic, that is, he's sweaty, kind of cold and clammy, And he has that sort of ashen blue color in his lips and also in his fingertips. She notes that he has really 1 to 2 word dyspnea. That is, he can get 1 or 2 words out before he has to stop and take a breath. And he's also using the accessory muscles of respiration. You can see his sternocleidomastoid and trapezius muscles in his neck. If you pull up his shirt, you can see the skin suck in between his ribs with every breath. He has a strong bounding radial pulse, which says probably he has a pretty good blood pressure off the top. The nurse does a little bit more of an exam, puts his stethoscope on the patient's chest and notes that there's some quiet wheezes in the top of his lungs in the apex. I would predict this guy wheezes every day. So the wheezing may not tell us very much, but the quiet might tell us a lot. So minimal air movement in the lower lobes, wheezing in the upper lobes. His pulse rate's 120, his pressure's 190 over 110, respirations are 24. Of course, this is an assisted living facility, so they don't have baseline vital signs because this isn't a medical facility. But I think you'd all probably agree a tachycardia at 120 is pretty high. Very few people are chronically that tachycardic. A pressure of 190 over 110 is unsustainable, and a respiratory rate of 24 is pretty quick. So the assisted living staff, the patient, the LTAC nurse, all had a conversation and made a call to the primary care provider, and they decided that they were going to transfer him directly to an acute care ICU for further assessment and stabilization. So EMS was called, and they transported him with that incident to the hospital. And this was really a direct admit into ICU, so he did not stop in the ER. That is a little unusual, but that's just how this worked in this particular community. So now we're looking at the notes from the ICU intake on this patient. The nurse in the ICU noted that he was alert and oriented. The patient says his shortness of breath got worse during the transport. Head and neck, you could see pale and diaphoretic. Really nothing new in the assessment that we didn't already get from the LTAC nurse. Vitals, he's a little more tachycardic than he was before. His diastolic pressure is up a little bit, and he's still pretty hypertensive. Respiratory rate is slowed to 18, which we'll talk later as to whether that was a good sign or a bad sign. He is not febrile. They put him on a pulse oximeter, and his oxygen saturation was 90% on the 6 liters of oxygen, which is his normal oxygen dosage, and his end-tidal CO2 is 64. We're going to talk some about the importance of end-tidal CO2 as a measurement for patients to determine whether their ventilation is adequate or not. This tells us that he's not ventilating particularly well. They did an initial chest x-ray, found that he had a big heart, cardiomyopathy, which is probably related to his chronic lung disease, and was not far from the baseline because he'd been in this ICU before. He had pulmonary hyperinflation, in other words, his lungs were giant, also typical with emphysema, and a little bit of right infiltrate with atelectasis, so maybe the start of a little pneumonia. So overall, nothing ghastly there other than the end-tidal CO2 tells us that he's not ventilating very well. So the treatment plan was to optimize some bronchodilators, give him some antibiotics so that he didn't develop pneumonia, and continue his supplemental oxygen. He had terminal chronic disease. And so although the ICU started with these relatively unaggressive measures, there was an agreement based on the patient's wishes, his family's wishes, and his primary care physician was the communicator of those wishes, that he was not to be intubated or ventilated. And over the subsequent 36 hours, his gas exchange deteriorated first. That is, he became more hypoxic. His mental status followed that. And not unexpectedly, he died with his family at his side. So not a great ending, but sometimes we see that in patients who have chronic obstructive lung disease. Before I start into the discussion of this, just a quick reality orientation. You all can hear me and you're all still there, right?
Yes.
I can hear you.
Yeah.
Perfect. Standing alone in my office here, there's just always the chance that somehow we've been disconnected and I'm just happily chatting on to myself. So I wanted to make sure that wasn't happening. Let's talk about what chronic obstructive pulmonary disease is. We'll talk about what I mean by this a little more in detail in a second, but COPD affects both ventilation, that is the ability of air to get in and out of the lungs, and diffusion or oxygenation, that is the ability of gas to exchange. So chronic obstructive pulmonary disease is kind of a double header in that it creates both oxygenation issues and ventilation issues. And the root cause of that is irreversible airway obstruction. When you see that little graphic there on the right, the little light blue thing represents an alveolus. You have 100 million of those in each lung. And when we breathe in, the walls of the alveolus naturally pull out. That is, our little bronchioles get bigger when we breathe in. And the simple reason is the walls of our bronchioles are attached to the pulmonary tissue that is sort of adhered to the inner lining of our chest, which means when I pull my chest out, it pulls all the lung tissue out also, and it opens the airways to facilitate even more air getting in. Now you can see that little, on my screen it looks purple, those little obstructions on either side of the bronchiole. That represents what is an irreversible airway obstruction in the patient with COPD, caused by chronic edema and also scar tissue. But when I breathe in, the walls of my airway dilate out and air goes into my alveolus just like it's supposed to. But then when I breathe back out, naturally, and this happens to all of us, our airway, the bronchioles, get a little bit narrower because my chest wall has come in. And as a result of that, air gets stuck in there. So COPD and asthma works the same way. It's what sometimes we refer to as an air trapping disorder. Patients can breathe and get air in, but they have trouble getting the air back out. And over time, their chest just gets fuller and fuller and fuller. And you can see that on an x-ray. Symptomatically, the patient will tell you that they can't get any air in. And the reason is there's no space. All that air's gotten trapped in there. So the obstruction causes air trapping. That alveolar wall overinflates, and just like a balloon, when you blow it up, you can see that the wall is getting thinner, and whatever was written on the balloon, like Red Robin or Bob's Garage, you can see it get stretched out as the alveolus gets bigger. And over time, that hyperinflated alveolus gets thinner walls. And you'll also notice, and this will be important later when we talk, as the alveolus gets bigger, it starts to compress up against the pulmonary capillary that goes around that alveolus. And that ultimately is going to cause some cardiac problems, some right-sided heart failure. The other thing that happens, and there's not a good analogy on the balloon side, but imagine that if I blew a balloon up, left it blown up for 2 weeks, and then I took the knot out of the neck of the balloon, and it didn't go, but instead the walls had gotten all saggy and they didn't recoil back down. You leave these alveoli hyperinflated long enough, and they don't naturally recoil closed, which also means that now, as a patient, I need to squeeze my chest closed to push the air out. And that creates a lot of the respiratory effort that we see in these patients. Why does it occur? Well, it's scar tissue, and the number one cause still, although in the US we've made huge strides, still the vast majority of patients you and I see with COPD are smokers. So one other thing to mention, if you're paying attention and you're saying this is, and you're hearing me say this is irreversible, you might ask yourself, why is it that we bother treating these people? If it's irreversible, then I can't fix it, right? Going back to this slide, there, in addition to that airway obstruction caused by those little purple pieces of scar tissue on the sides, there is also bronchospasm involved here too, because of irritation of the airways caused by that scar. When you and I give them bronchodilators or steroids or whatever to try and improve this, it's that reversible part, that bronchospasm, that we're fixing. But the scar tissue remains as the scar tissue. So here's a patient who's had this probably for 30 years, I would guess. He died in his 60s, and he probably began to be symptomatic. He was a heavy smoker and continued throughout his life. He did not stop late in his life, as some do. So the long-term consequence is that those high-pressure, thin-walled alveoli begin to consolidate. You get a bunch of those soft, thin-walled alveoli up next to each other, and they sort of mush into one. So where a normal alveolus is smaller than the size of a head of a pin, you sometimes, with patients like this, will see an alveolus that's the size of a quarter. And what that is literally hundreds of alveoli kind of smooshing into a single bleb. Because each of those alveoli had a pulmonary capillary that went around it, and that was the surface where gas exchange occurred, as you start to change 100 alveoli with 100 pulmonary capillaries to one big mushy alveolus with one pulmonary capillary, we see a tremendous loss in the surface area for gas exchange, which means those patients typically become hypoxic. Their oxygen saturation drops, and like we saw with this patient, they end up having to be on long-term oxygen therapy. And then, as I mentioned, the loss of elastic recoil forces active exhalation. So we also see chronically hyperinflated alveoli compress the adjacent capillaries and create right heart failure. I mentioned that before. So now we've got that big overinflated alveolus, and it's squishing up against the pulmonary capillary that goes around it. You can see there I've marked that the blood flows from the right heart to the left heart. That little arrow there in the capillary is showing you direction, and you can see that that big overinflated alveolus is compressing up against the capillary, and is going to cause backup of fluid into the right side, and we typically see patients who have chronic right-sided heart failure as well. So all of those things happened to this patient. Remember, I said at the top here, one of the things that is important for us to keep respiratory compromise from turning into respiratory failure and death is early monitoring. And there are a couple of tools that you and I have access to, hopefully easy access, but if not, you probably need to try and encourage your organization to provide you with easy access. They aren't real expensive. An end-tidal CO2, also known as a capnometer, measures the exhalation of carbon dioxide out of our lungs and is a very accurate reflection of how well air is moving in and out, the act of ventilation. So the end-tidal CO2 in the early stages of perceived respiratory distress, usually, and we saw this in this patient, his symptomatic belief that he had shortness of breath and distress caused him to breathe faster. In the early stages, in a patient who has relatively normal lungs, that tends to blow off carbon dioxide. Normal end-tidal CO2 is 35 to 45. In this early stage, when people hyperventilate, this would be especially true for asthmatics, we tend to see their end-tidal CO2 go below normal because they're hyperventilating. As the obstruction continues and we start seeing an impairment in exchange of gas, then we start to see an impairment in ventilation, and we suddenly start to see the end-tidal CO2 climb above 45. That's evidence to us of inadequate ventilation, so we may need to help them with that. Permanent obstruction oftentimes leads to chronically high end-tidal CO2, and the body does some tricky things to keep chemistry balanced in that case, and we aren't going to go into that today. A waveform capnograph is even better because you can look at the shape of the waveform and identify the nature of the obstruction. Not the focus of our discussion today, but a waveform capnograph helps you understand the why. The end-tidal CO2 answers the question, are they ventilating normally or not? Waveform can tell you why. On the oxygenation side, you have a pulse oximeter, and again, hopefully all of you have, oops, sorry about that. Let me go back to where I was. Hopefully all of you have access to a pulse oximeter. What we tend to see is in mild to moderate now asthma, which is kind of in the category of COPD and obstructive lung disease, typically people maintain their oxygen saturations just fine, somewhere in the vicinity over 90%. I live in Colorado at high altitude, so we normally see patients at 91, 92% as normal. You typically will see them, I would guess, 92 to 94. However, if bronchospasm gets bad enough and it reduces my ventilation enough, the reduced ventilation will lead to a decrease in my oxygenation, and my SpO2 will drop below 90, which typically is when we want to put people on oxygen therapy, even just for a brief period of time. Patients like the one we just looked at who have COPD and extensive permanent damage oftentimes have chronic pulse oximeter less than 80%. This gentleman's baseline off of oxygen was probably between 78 and 80%, necessitating long-term chronic oxygen use. So what are we looking for? And these signs and symptoms will go across our other cases. Any of you that are looking going, holy moly, we're 30 you know, we're only 30 minutes in and he's doing 3 cases, we're going to be here all afternoon. Nope, I don't think so. But the classic signs and symptoms of respiratory compromise include changes in the respiratory rate. Most people start to breathe faster when they feel subjectively short of breath. Heart rate variability, that's a key one. One of the things that respiratory compromise, yes?
With the weather putting a hinge in things, let's do next week.
Oops, somebody just unmuted, I think.
I can do really early morning or later afternoon.
Whoever's talking currently about meeting early in the morning, if you could mute your audio for this talk, that would be great.
5th at 11, that's too late in the morning. I have to go to Crawfordsville that day.
You can go ahead. Yeah, feel free to go ahead, Dr. Bourne.
Okay.
I think I have it muted.
Great. Heart rate variability is an important one. All of the patients that we just looked at had tachycardia, or the patient that we just looked at had tachycardia, but one of the things we often see in the earlier stages of respiratory compromise is they will be tachycardic, and then it'll sort of swing back into normal. Sometimes it can get a little low and back and forth, so watch for that. Abnormal effort of breathing, which we see, as we did with this patient with retractions, use of the accessory muscles of respiration. Breath sounds. At this stage, what I would tell you is the most important part of the breath sounds have to do with, is there any sound? In trying to determine who's in compromise and who's not, I'm less concerned about whether it's wheezes versus rales versus rhonchi, as I am that they're moving good air. I can hear volume. Now, that becomes easier to appreciate if you've listened to a lot of lungs. So get all the practice you can. Altered mental status as it gets worse, cyanosis, and then the changes in SpO2 and end-tidal CO2 that we've talked about. We've already really gone into both of these things, so I'm going to skip past them. This particular patient probably presents with one of the most common causes of respiratory compromise that you and I will see. Between patients who have irreversible obstructive airway disease, COPD, as we just discussed, or reversible obstructive airway disease like asthma, they present very much like this patient did, and the use of physical assessment around are they moving air or aren't they, the things we just looked at, how bad is their distress, tachycardia, use of accessory muscles, and then the use of end-tidal CO2 to help me understand are they moving adequate air or not. If it's between 35 and 45, they're doing great. If it's over 45, they're not ventilating very well. If it's under, they're hyperventilating. And then the use of pulse oximetry to identify are they adequately oxygenated. We'll talk at the end of this talk about what we're going to do with that information. But this patient presented with classic signs of respiratory compromise in the earlier stages that ultimately he did decompensate and developed respiratory failure and ultimately death. So let's look at a different case. This is a critical care transport case of a patient who is being transported into an LTAC. Her name was Kathy, and she was a 20-year-old woman who had agamma-globulinemia, which is a genetic disease that results in essentially inadequate gamma globulin and white blood cells, which impairs patients' ability to fight infection. Not important that you be an expert in agamma-globulinemia, but it is valuable to know that patients who have this disorder are much more prone to infection, any kind of infection. In this case, she's had recurrent pleural infections and pleural effusion. Let's break those down for a second. The pleural space is the space between the edge of the lung and the inside of the chest wall, the pleural cavity. Effusion means that there's inflammation in there, and infection means that inflammation is actually bacterial. And so she ends up with a collection, a pleural effusion that's fluid and pus that's infective. The net result of that as a patient, and I'll show you a picture of that in just a second, is it compresses otherwise good lung tissue and makes it harder to breathe. So she's being transferred into an LTAC to have her infection and effusion managed. So the EMS folks during transport took a look at her. She's alert, she's oriented, but she looks really tired. And Kathy actually pretty much always looked pretty tired because it was a lot of work to breathe with her chronic respiratory infections. Her primary complaint was focal right-sided chest pain that mostly hurt when she inspired and expired, and shortness of breath. She was pale, and again, this is a woman who's almost always pale, diaphoretic and retracting. Her pulse rate is 110, her pressure is 108. She also is afebrile, and her respiratory rate is 20. So here is the information that the transferring medics got before they moved the patient into LTAC. The sending facility provided them with some information. She's been having more of these over the past 5 years, and I mean, the reality for her is I would predict she will probably die by the time she's in her 30s or 40s, and it will be of some infection that couldn't be controlled, because the core problem with agammaglobulinemia is her body's ability to fight infection. On initial presentation, her SpO2 was 74%, so she is quite hypoxic. It's no wonder that she's pale, and it's no wonder that she feels short of breath. Her end tidal CO2 is 48. You may remember when we talked, normal ventilation, or normal end tidal CO2 is between 35 and 45. So she's nearly normal, but she's abnormal in the direction that says she's not moving good air. This is good news, but remember, we see her in respiratory compromise as someone who's at high risk of getting worse. So the SpO2 tells us her oxygenation is already subnormal, and the end tidal CO2 tells us she's hanging on by a wing and a prayer, if you will, from a ventilation perspective, and we need to be prepared to ventilate her. Her white count's elevated, and you can see here on the right side of the screen her pleural effusion. I believe you can see my little arrow, so that right pleural effusion is this area right down here at the bottom of the right lung field. And actually, you can see just a little bit of a line at the bottom of that, and that's the water level, if you will. Part of the really good way of diagnosing a pleural effusion is to turn her on her side and take that chest film again. And there you can see the water line of the fluid that's in her pleural space. And that is probably compressed a third of her lungs on that side. So it's no wonder that she's having a little difficulty ventilating and thereby oxygenating. She also has, you can see here on her fingers, this is a condition known as clubbing. There are a host of things that can cause clubbing in the fingertips. You rarely see it in the toes. And the one thing that draws them all together is they are all disorders that cause chronic hypoxia. So when I see this on Kathy's hands, I know this is not the first time she's ever been hypoxic. The rest of her assessment, you can see there, nothing too dramatic. She says her head hurts a little bit. That may be caused by the hypoxia. She has a cough, but no production. Decreased breath sounds, and rhonchi, which tells us that she's got mucus bubbling around down in there. Otherwise, a fairly normal assessment. So the EMS team, she is likely to get worse, so they're bracing for respiratory compromise. They want to continue to monitor her, plus they need to continue the therapy that was started in the hospital. So they put her on they run an EKG and just cardiac monitor. She has a line going. She also has a line with Keflex running via an IV pump. She has a chest tube on the right that's hopefully sucking out some of that pleural fluid to allow her lung to re-expand. And they have her on oxygen to get her oxygen saturations up in the 90% range. So now she's arrived in LTAC. Some of you may work in an LTAC, and so this patient's now come to you with essentially hypoxia, barely adequate ventilation, and the possibility of continuing infection. So your treatment plan reflects that. An effort to improve her ventilation, because remember her end tidal CO2s were just out of normal, with CPAP every 4 hours or as needed in order to get her end tidal CO2s back in a normal range. Regular pulmonary hygiene to make sure she doesn't get pneumonia. So some deep, a blow bottle or some bronchodilators, those sorts of things. Supplemental oxygen in order to keep her oxygen sats in the normal range. Continuation of the antibiotic therapy. Those of you that work in LTAC, or quite honestly any acute care facility, you are unsung heroes who prevent all kinds of complications by frequent position changes. And the word ambulance, I just noticed, shouldn't say that. It should say ambulation. So you get her up and walk her around to prevent DVTs, to keep the mucus moving in her lungs, and so on. ongoing assessment for signs of systemic sepsis. One of the things, right now her infection is localized in her right lung and in that pleural space. What we want to make sure it doesn't do is turn into pneumonia or turn into overall systemic infection or sepsis, which then would set her up for septic shock and death and those kinds of things. And then probably daily chest films to assure that her pulmonary or pleural effusion is getting smaller. So let's talk a little bit. She's an example of one of those categories of causes for respiratory compromise that we discussed, parenchymal lung disease. These are diseases that affect the tissue around the alveoli, like pneumonia infection. That's what Kathy has. Environmental exposures, silica dust, coal mining, those kinds of things. Lung cancers, occupational exposures, collagen vascular disease can do it sometimes. And there's a ton of patients who have parenchymal lung disease that we can't really figure out what caused it. So what happens when you have a parenchymal lung disease is you have compressions around the bronchioles and the alveoli. So now the narrowing of the airways, where before was scar tissue inside the airways themselves, now that compression is coming from outside and compressing the bronchioles from the outside because of tissue damage. Remember when you looked at Kathy's chest film, a third of her lung was getting squashed over, a technical pulmonary term, because of that pulmonary effusion. And so now suddenly the airways and the alveoli are getting compressed from the outside. That, like patients who have obstructive lung disease, have impaired inspiration and expiration, and then ultimately a slow collapse of the alveoli. Once that airway, looking at the lower left little diagram, once the compression is so great that even on inspiration, that airway doesn't open up, then the air that's in there keeps exchanging with the pulmonary capillary. And as that exchange goes on, the amount of air that's in the capillary goes down and down and down and down until ultimately that alveolus collapses. And the word that we use for a collapsed alveolus is atelectasis. Once that alveolus collapses, now I have an oxygenation problem in addition to my ventilation problem, because there's no air in the alveolus at all. So the longer that inflammation and infection, or whatever the parenchymal cause is, goes on, the more that occurs. So we have localized infection and systemic infection. We want to keep it localized so that they don't get systemic infection and death. So now, looking at this one, you may not see a lot of pulmonary emboli, but you probably do see pneumonia, and you see patients with other lung disease in which the disease compresses the lung tissue. The net effect is a lot like the net effect that we saw for COPD, plus you have a net effect related to infection. But at the end of the day, we're looking at the same two factors. How well are they ventilating? I do a physical exam, look, listen, and feel for breathing, listen to their breath sounds, and so on. And then I can get a more precise picture by looking at their end-tidal CO2. And then my other question, how well are they oxygenating? And again, I can do a kind of a gross exam looking at their mental status and their overall skin color. But better yet, let's look at a pulse oximeter and identify whether they're adequately oxygenated. So now to our last case. This one was a 911 call, but quite honestly, you see this constellation of symptoms just as frequently, or perhaps more so, in patients that are in long-term care facilities, skilled nursing facilities, places where they tend to be immobile and have chronic diseases. This was a 54-year-old woman complaining of stabbing focal chest pain that went through to her back. It started about an hour prior. She couldn't take it any longer, so she called 911. Past medical history includes phlebitis, for which she takes Coumadin, and she is a smoker. She presents with pale skin, strong radial pulses, vital signs that are not too far out of whack, clearly not as far out. These patients have gotten more normal in terms of vital signs from our first case to now, although the respiratory rate of 32 in labor tells us she is subjectively, at least, very short of breath. Some more detailed assessment by the paramedic. She's got normal breath sounds, clear and crisp and moving good air. She has big neck veins, jugular venous distension. Her SpO2 is 87% on room air, so she's hypoxic. And here's a point that I want to make here, and we'll look at it in more detail in a minute, but she appears to have normal ventilation and appears to have inadequate oxygenation. Based normal ventilation on my gross assessment of her breath sounds, and oxygenation based on looking at her pulse oximetry. That's kind of an important picture for the way that she's presenting. She has no evidence of redness or swelling in her legs. A good thing for the paramedic to look at, because remember she has a history of phlebitis and a presentation stabbing chest pain that's somewhat like a clot in the lungs, a pulmonary embolus. So the medic is looking to see if he or she, and I don't recall which, I didn't interact with the paramedic on this case, but looking for signs of worsening phlebitis or perhaps a DVT in the legs. Cardiac monitor is normal. Paramedic's initial intervention was 5 liters of oxygen, which was enough to get the SAT over 90. Start an IV simply because if she gets worse, the paramedic's preparing for, is assuming this patient's in respiratory compromise and can get worse. They want to have IV access in case they need it. There's no therapeutic need for it now, but it's sort of a just in case maneuver. Transported to the hospital, which is where I saw her. She said that she stated that she really felt a little bit worse, and the paramedic said she's much more restless. She looks much more disturbed. Drop to the bottom of this page, and you can see she's more tachycardic, she's more hypertensive, and she's more tachypnic. So, so really just a worsening of the symptoms we saw in the field. Additional ED assessment, we did an INR, which was 0.9. We consider normal as 1 or above. Some of you may, in your hospital, still be using ProTime and PTT. Her PT was 9 seconds. Those two things both mean the same thing, which is she's clotting a little faster than we would like, which is something, of course, that the Coumadin is trying to resolve. And so either she's not been taking her Coumadin or it's no longer a therapeutic level. Her end-tidal CO2 is 34. Remember that normal end-tidal CO2 is 35 to 45, so she's ventilating just fine. In fact, she's right on the edge of hyperventilating. The good news is she's moving good air. She doesn't need our help to ventilate. However, it's taking 10 liters of nasal oxygen to keep her SATs in the 90s. So she's got a clear oxygenation problem. So we sent her off to get a chest x-ray, which looked normal and was not surprising, and then we sent her off for what's called a ventilation perfusion scan. And we're looking at it now, and as you look at that scan, one thing that seems profoundly missing there is her entire right lung. So what we see is that there's no perfusion through the pulmonary vasculature on one side, or excuse me, her left lung, sorry about that. So there's no perfusion on her left side. She has a complete occlusion of her left pulmonary artery. Based on the size of that and the fact that she was getting much more agitated, much more restless, her SATs were dropping down into the 60s from time to time. We initiated some fairly aggressive therapy and whipped her up to ICU. High flow oxygen, started another line, and began thrombolysis with the hope of breaking up that clot in some sort of a safe fashion. ICU, they continued thrombolysis, did a repeat ventilation perfusion scan that showed that the embolus had been lysed and that normal pulmonary flow was restored to the left lung, and she was discharged with instructions that it really would be good for her to stop smoking. So she had a pulmonary embolus. There were 2 causes at the bottom of that list of causes that both had to do with cardiac failure and pulmonary blood flow. And so pulmonary embolus is another cause of respiratory compromise, and like this woman's case, can deteriorate very quickly from being respiratory compromised to respiratory failure and death. Pulmonary embolus is a perfusion problem that impairs oxygenation. There is a clot. We go back to our same little diagram. There's a clot that prevents blood from flowing through parts of the pulmonary vasculature. This clot makes it look like it's just around this one pulmonary capillary, which is not the case in this patient's case. It was clear up at the origin of the left pulmonary artery, but the effect is the same. We have good good airflow in and out of the alveoli, but no circulatory flow in the affected area. Ventilation is fine, and oxygenation is stopped in the areas that are distal to the embolus. Now, how bad it is depends a little bit on where it is. Looking at that diagram on the right, the one at the top is a massive embolus that has occluded both the right and the left pulmonary artery, i.e. there is no longer any circulation in the lung. That patient will die very quickly unless it's recognized and restored. The patient that we just saw has the one in the middle, which is a pulmonary artery branch thrombus, and so her entire left pulmonary artery was occluded. The one at the bottom are what sometimes are called shower emboli, where there are just little emboli downstream and they dissolve and they move on and then new ones go in. How dramatic the patient's symptoms are and how lethal the problem is depends primarily on where that clot is located. So it decreases oxygenation, which is what we saw in this patient, also decreases return to the left heart. So the patient in the top diagram, that massive thrombus, there's no blood going from the right to the left heart. It's leaving the right heart, and it's totally occluded by that clot, which means that they're in cardiac arrest. So there's no longer any blood flow out of the left heart. Smaller ones have less of an impact on left heart failure. It may cause adult respiratory distress syndrome long term, but there's no airway consequences. So this patient had perfectly normal ventilation. We did not do an end-tidal CO2 on her, but if we had, well, actually we did, sorry about that, and it was relatively normal. So airflow is fine. This is a circulatory problem. They're predictable, and they occur in patients that you and I see every day in our clinical practices. People that are bedridden or immobile are likely to get DVTs. People who are post-op from long bone fractures are likely to get a fat embolus. Pregnant women, although it's infrequent, it can be catastrophic, get amniotic fluid emboli. Phlebitis can cause venous. Smoking can cause clotting, as can birth control pills overall. As it relates to our discussion today about looking for respiratory compromise by identifying how adequate is ventilation and how adequate is oxygenation, on the ventilation side, it's unaffected. Because they're hypoxic, they usually breathe fast. And so we tend to see people who have an end-tidal CO2 that is less than normal, reflecting their hyperventilation. Again, the power of this tool is, in very quick order, you can identify this patient's ventilation is fine. So I don't need to prepare to intubate them. I don't need to ventilate them if they're in ICU. I don't need to alter their ventilator rates, that sort of thing. On the other hand, oxygenation is likely to be impaired by PE depending on the location. The worse the PE, the lower the SpO2 will go. As I said, this woman had SpO2s that dipped into the 60s from time to time as we were managing her. And wildly variant SpO2s suggest those shower emboli that I was talking about before, and those can be very scary to manage. So again, the use of these two tools help us. It is important that we try to prevent pulmonary emboli. Part of it's not doing things that are really risky. And again, those of you that work in inpatient facilities, you are the frontline preventers of pulmonary emboli by regularly turning patients, getting them up, walking them when you can, TED hose, mild exercise. It's also good to not smoke, and for some high-risk patients, birth control pills also provide a risk. And then we also try to reduce clotting. Remember, this woman was on Coumadin, with Coumadin or heparin, and then there are newer generation drugs that I'm sure you see on TV almost every night about that. So let's sum this up. What am I hoping you can take away from this discussion? First, an understanding of what we're talking about, that respiratory compromise is a deterioration of respiratory function that has likelihood of getting worse if you don't pay attention. And so our job is to really monitor patients carefully to assess their ventilatory and oxygenation status and be on the ready to do things to prevent it from getting worse and to mitigate decompensation. This is that same list that we started with. There in the compromise side, we can see those 6 causes: impaired control of breathing, impaired airway protection, and so on. On the right side, because it helps me think about it, I have added, is it a ventilation problem or is it an oxygenation problem? That's useful when we start thinking about what we're going to do to mitigate the problem. And we'll talk about that more in a second. So my assessment, first look and see if there's a life threat. Our EMS colleagues and our Our emergency department colleagues are the ones who are really the experts at recognizing who's going to die really soon, and then evaluate their history of current episode and respiratory and cardiac signs to figure out, does this person look like they are in respiratory, that they have respiratory symptoms? That's the start of our definition, is a patient who has respiratory symptoms that might get worse. So look at that first. Keenly assess ventilation and oxygenation. From a physical assessment perspective, ventilation, I look at air movement, I look for, overall labored breathing, use of accessory muscles, and so on. But the best way I really can assess that is through the use of capnometry. If their capnometry is between 35 and 45, they're breathing okay. It doesn't mean they'll be breathing okay forever, but right now their ventilation is adequate. If it's less than 35, it means they're breathing fast and deep, they're hyperventilating. Maybe I should try and figure out why that is. Hypoxia is one of the prime causes of that, but there are others. And if it's greater than 45, they are inadequately ventilating. I might be able to use waveform capnometry to explore that cause. On the oxygenation side, how are they doing oxygenation-wise? Are they normally oxygenated, or are they poorly oxygenated? And then I take action. I started at the beginning by saying the great news for you and I is I don't have to necessarily understand the cause in order to take the appropriate initial steps. If it appears that their ventilation is inadequate, I need to open their upper and lower airways. Some of that's simple, reposition their head. Some of that can be bronchodilator therapy. Some of it may require an ICU or an LTAC. You may need to intubate them or double check the patency of their endotracheal tube. If you think if you're not 100% confident that the tube is in position, take it out and reintubate. Then utilize a bag valve mask or a ventilator and adjust the rate and depth, what all of us in ICU and LTAC call minute ventilation, in order to achieve an end tidal CO2 in the normal range. The beauty, again, I don't have to understand why they're not ventilating adequately. I just need to try to get them back in the normal range by opening their airway and assisting in their ventilation. If their oxygenation is inadequate, first make sure they're ventilating well. Remember, our last patient is really the best example of that. She had great ventilation, but inadequate oxygenation. So begin by looking at ventilation, and if the ventilation is inadequate, that may be the cause of the oxygenation problem. Once you've got adequate ventilation, then work on supplemental oxygen flow rates to get the SpO2 over 90. If unable to normalize, consider the causes, and then we start to have to understand more about what the cause is. Is this pulmonary embolus? Is this congestive failure? We're going to need to turn to our colleagues on the medicine side to help us understand the nature of that and to create a more specific therapeutic plan. But in the interim, we can do things to try and stabilize them out. And it looks like we've got just a couple minutes. I certainly am available beyond that to take questions. But I appreciate having the chance to chat with you all, and I think they're going to open the floor to questions.
Yes, if anybody has any questions, please feel free to chat those in the chat box, and we can forward those to Dr. Bourne.
Dr. Bourne, this is Karen Kennedy with the Indiana Hospital Association. I just want to say thank you for this excellent presentation. I like the case examples, walking through those, and the way that you tied it in at the end. So thank you so much for presenting this information.
It's my pleasure. I appreciate having the opportunity to talk about something that all of us can do better. So thank you so much. I have on the screen some other resources. I just want to kind of frame that. If you're interested in learning more about this, here's a couple good places to look. And now I may have just stepped on somebody's question. Sorry about that.
Yes, the question is will this presentation be available after this session?
I'm more than happy to make it available. I don't know the logistical solution as it relates to whether you're going to post these or anything like that, but I'm happy to make it available to whomever needs it.
Yes,
Yes.
if you could, go ahead, Shelby.
I actually, Dr. Bourne, I can send out the webinar recording, and then if you want to pass along the PowerPoint presentation, I can include that in the email that goes out to all of our participants in the project.
Oh, that'd be great. I think probably the webinar recording will be the most useful tool, but I'm happy to send on a PDF of the presentation for anybody that wants to review it in more detail.
Great, thank you.
We did have one question, Dr. Bourne. Someone had asked, just they mentioning or suggestions, some suggestions about how different care settings can communicate among one another. So we do have some long-term care facilities online, as well as EMS and then hospitals. So how might they better communicate amongst the different care settings to ensure that there's successful handoffs and transfers?
You know, I was afraid that you were going to ask some sort of a simple question like you know, world peace or something like that. But you know, this becomes a system question. Each of us as an individual clinician can do a couple things to help with that. I know, having spent a good part of my career in EMS and also in the emergency department and ICU, during that patient handoff, whether I'm the sender of information or the receiver, I need to make sure that I think through what information would this person need to know, and can I provide documentation of that, like hospital records. When we transferred Kathy, the woman with agammaglobulinemia, that x-ray was important to the receiving facility, as was a little bundle of clinical data as well. And I think I've been through too many of those handoffs where the sending facility was simply, just take the patient. And we're like, I think the receiving facility is going to need this information. And oftentimes the sending facility was looking at me as a paramedic saying, you can't read this x-ray, so why would I give it to you? And number one, that may or may not be true, but number two, you're not giving it to me. You're giving it to your colleague who's going to care for this patient in the LTAC. So if you're the sending facility, and again, it could just be from the floor into ICU, from a community health center into the ER, whatever, think about the data that was most useful to you and see if there's a way that you can summarize it or actually send a copy of it. HIPAA doesn't apply here. You're sending it to somebody else who's going to care for the patient. And if you're the receiving facility, you know, if you're EMS doing the transfer, don't say, I don't need those stinking x-rays. Ask a very pointed question, which is there any clinical information you have that the place I'm going, and they know where you're going, so the LTAC or the inpatient facility or whatever, is there information that I need? I'll wait while you get it for me. So those are the things that all of us can do in our day-to-day interactions to try and facilitate that transfer. Is don't be in such a big hurry. Make sure that if you're the sender, that you send the data that's important. If you're the receiver, that you ask for that data and you try and hang on until you can get it. From a system perspective, I think there are some things that systems can do if they all agree to it, and that is to create a checklist of information that says, if I'm transferring care of a patient from X to Y, and again, it could be as simple as from the emergency department to an inpatient facility, from a SNF to an LTAC or whatever, this is the data that we have all agreed is clinically important. And then the receiver of the information need only to look at the checklist and say, okay, here's item 1, here's item 2, here's item 3. Oops. I see that we don't have the discharge summary. Could you get that for me? And since we've all agreed on that, we don't have to have an argument at that point about whether that matters or not, because we as a healthcare system or as a community, because oftentimes it'll be among different systems, but if as a community we've all agreed that's the information, then that helps. So I think day to day we all can do a lot, but ultimately the solution's in the system, and I think a checklist is a good place to go.
Great, thank you. I thought that's an excellent close to the webinar today. And I did see where Scott had posted that Lee Varner has a great sample handoff form. I know that was something that came out during our recent road shows that the Center for Patient Safety helped the Indiana Hospital Association with. We'll make sure that that form gets handed out and distributed to everyone participating in this project. So thanks for bringing that up, Scott.
I'm happy to help. Anytime I can throw a softball to Lee and the guys at the Center for Patient Safety, I will do it because they've got lots of great stuff.
Okay. If we don't have any other questions, we're just a few minutes past the top of the hour. We'll go ahead and close for today. And again, Dr. Bourne, thank you so much for this excellent presentation. And we will definitely be getting out the audio recording to those who may not been able to join us today, or if others want to share that within your facility, that would be great too.
Thank you so much for having me. I appreciate it. And it looks like you're going to have a great series of programs here. So enjoy it, and I hope you find it valuable.
We did. Thank you so much again.
Okay. Bye-bye.
Bye.